What we understood from all these scales and strokes is that our window of opportunity is actually very low. Okay, what we've understood is most of these patients are not going to do well. We've understood that most of our patients are not going to do well. हमको ये पता चल गया है, okay? हमको पता है कि अगर कुछ भी नहीं रहेगा तो वो पेशेंट ठीक रहता है. अगर पेशेंट को कुछ भी ब्रेन में होता है तो they end up having problems. That is very clear. Okay, so our window of opportunity for any of us, for our relative, for our own patients, is very tiny window of opportunity. Okay, and that's why most of the things that we talk about in brain, usually most of the things that talk about brain is related to timing. The more faster, that's why a stroke center excels more than a normal hospital, because the stroke center understands this importance of timing. The stroke center understands the importance of timing. You are clear on this?
Yes.
Clear? This is coming on this also. On this
Yes,
also.
sir. Yes, sir.
Okay. Stroke center is so important. That's why the golden hour is something that is very important. Now, what is we say when we say golden hour? We're probably going to go to golden hours now. We are not anymore in that golden hour kind of condition. Okay, we are now in golden hours. So how do we go to golden hours? That is a big question. That is a big question. So China 76 to 150 strokes per 100,000. Australia 160. Okay, Australia is 160 per 100,000. UK is 130 per 100,000. India's statistics are not really available, but we know it is somewhere upwards of 130. It might be even higher than that. I'm telling you, statistics in India are so horrible that I'm telling you, it will be much higher than what is being projected. It is being projected as 130 per 100,000 population. We are a 1.2 billion country. So the number of strokes are, if you actually look at the quantity in this, is very high. You understand? It's 130, 145 per 100,000, right? But there are 1.2 billion population we have. So you can just imagine how many strokes may be occurring in an average, day or an average month or an average week or an average year. It's huge. It's only that it's not being calculated as to what it is. So you can very well say that in your entire life as a doctor, as a journey as an intensive care doctor, you're going to see multiple strokes all your life. You're going to see multiple strokes, that is certain. And these strokes can't be treated in nursing homes. They will come to you as in hospitals. They're not going to be treated at home. These are few things that a heart and a stroke. These are two things that without going, how much of a telehealth you may improve, it will come to the hospital and you will be taking care of these patients. Okay, that's why knowing that is very important. Right from how to recovery, how to go into rehabilitation, how to go into improvement. This is the biggest issue. How much they recover, how much they rehabilitate, and how much they improve. That is what we were talking all this time. That if the GCS is very low, they go into rehabilitation. If the GCS was better, they probably get functionally improved. They recover faster. So we're talking about the same terms again and again. And I think why this slide is so important, because 1.9 million neurons are being lost with every minute of delay. How many? 1.9 million neurons are being lost with every minute of delay that we have. We might say, "Arey, isko time lagega." But what you must know is, we are losing 1.9 million neurons. Okay, this patient is not going to do well cognitively because of the fact that he is losing neurons. Neurons have been created over a period of years in your body. Okay, and then you are losing it. It is not going to regenerate. So in short, you talk to a patient's relative, you cannot tell him that he will be okay. It is not possible. It is not possible to be okay, because you cannot regenerate these neurons. If what is gone is gone. So if you delay by 50 minutes, you imagine the number of neurons you have lost. And each of those neurons are doing some activity in your body. They are doing something. Or each of the neurons are responsible for doing something or the other. That's why time is brain. At one stage, all that we could offer was an aspirin and a betadine. Okay, I've gone through that life where patient used to come with stroke. This is all that we could offer. Okay, this is all that we could offer at least 20 years ago. Okay, at least till I remember somewhere around 1997, 96. We couldn't offer anything more. All that we could do was give them an aspirin. This is all that we could have done. So many patients in the past have been remaining functionally completely bad, not able to get back to their activities. These are the things that people do. But things have changed now. As of now, things have definitely changed. There's no doubt. I'm very happy that I'm in this era where things have kind of changed. If within 4.5 hours we are now giving Activase. If within 4.5 hours we are actually giving Activase. Okay. If within 4.5 hours, now that also, if you think very clearly, 4.5 hours is a very short period. If you look at it. I mean, if you tell me today to come from Goregaon to Mumbai to Raheja and get myself thrombolized, I will be more than 4.5 hours. It is not possible only. It is not possible. If I come from Raheja, I come from my house, it's going to take 45 minutes from there to get into an ambulance. From there to come to here another 1.5 to 2 hours considering the traffic. And then after that you come here, फिर वो red tapeism as to what is to be done, what not to be done. 1-2 घंटा उसमें चलाएगा. 4.5 hours ऐसा जाएगा. So in short, if we have hardly any time, how can we affect a recovery? It's a very sad situation if you think about it. It's a very sad situation. You know, the right thing would be I have a stroke, patient comes, the person comes and does thrombolysis then. That would be the right thing to do. Unfortunately, our systems are so bad that we don't tend to have qualified staff to do this thing. We don't have qualified staff to pick up a stroke. We don't have qualified staff to even do any initiate treatment or relay back information. Unlike many other countries where stroke thrombolysis is initiated at site. Okay, I mean, there are places where they do that. So the force definitely is us only. There's no doubt about it. I don't think there's anything better than that. It's important to pick up the stroke. So, and which are the strokes? So if you look at the big picture of things, which are the strokes that will pick up? The ones that is in the hospital. This is the ones that probably we can salvage maximum. Patient has come for a TKR and got admitted to the ward and has developed a sudden weakness of his right side. That is the best possible patient that we probably can do, isn't it? If you think about it, you're not losing neurons as quickly, you're losing neurons, but you're quite early in time because patient is right here. So all the more reason for you to pick it up. So today you get a phone call from the ward and says this patient is unresponsive or patient is not doing well. You first think whether it's a stroke or not, because that is something that is time bound. So recently also we had a patient in the ward and we went on top to see someone of you went on top to see the patient. But rather than actually telling me about the stroke and its manifestations, you were telling me everything about his respiratory system, saturation, his vitals. It doesn't make sense at all to me. It doesn't make sense at all to me. Because what should be the first thing priority in your mind is a stroke. I rule out a stroke, then you decide what you want to do. You understand? Huh? So stroke is something very, very important. Picking up the stroke is very, very important. So how do you do this? So issue is what is this stroke after all? It is basically if you have these clots that are formed, if you pick up that stroke faster. This particular data that came out way back in 1995 explained to us that if you give tissue plasminogen activator to that particular stroke which is having a clot, there is a very high chance that this patient will do well. Alright, and then around 10 years later, after that, 2008, okay, this was in 1995, in 2008, they came out with a 4.5 hour window. So there are two windows. That's why it's important for us to pick up that stroke, because we have these two timings. Very important studies that came out from the NEJM. Extremely important studies for all of us to read, because these are the things that are the only change in mortality, or for that matter, morbidity will come to that. Okay. So if you look at the outcome. Now when I said the NIHSS score, we talked about NIHSS score saying we're going to look at outcome, isn't it? We looked at outcome therefore. When you talk about outcome, in these cases, with the NIHSS score, we're talking of 3-month outcomes. We're not talking about outcome in hospital or outcome out of hospital. We're not talking about that. So when you're also counseling your patient, you must think like this intelligently, that the NIHSS score is not telling you what's going to happen in 5 days. It's going to tell you what's happening in 3 months, at 90 days actually. Okay, it's at 90 days. So whenever we talk about outcomes, or in our NIHS, with respect to NIHS score or any score that we talk about, we're talking of 3-month outcomes, that is 90-day outcomes. So, भले ही तुम्हारा patient खराब हो, but if you do the GCS or the NIHS is on the lower side, NIHS the numbers are low, then you probably say, no, this patient will do well, don't worry. There's a chance that this patient is going to do well in 90 days, not now. Patient मेरा अभी तक ठीक नहीं हुआ, patient अरे मेरा patient ऐसा है, तभी भी ऐसे ही है, ठीक है, हम लोग 90 दिन पे देखने वाले हैं. Even the effect of that tissue plasminogen activator is at that is what you must understand. Very, very importantly, you must understand this. The TPA का effect जो होता है, हम logically may think like this. There is a clot. I gave TPA, clot opened, patient became normal. It is not like that. It is not like that. Clot, patient abnormal, you gave TPA, improvement at 3 months. That's what this entire slide is about. This slide is about all those scores that we were talking about. Now these are rehabilitation scores. Barthel index is a rehabilitation score. Modified Rankin scale is a rehabilitation score. Glasgow outcome scale is a rehabilitation score. These are very important scores, which are going to, which they at rehabilitation they will look at. Okay, they will look at. When you say modified Rankin score, if I'm at a score of 4 or 5, it means that I'm able to do my activities on my own. This is an important thing. If I have a stroke and I'm able to button my shirt and go for work myself, that's a fantastic recovery, isn't it? That is what we want. We don't want a person who is awake, cannot put his button, cannot eat his food. It is horrible to have a person like that, isn't it? It is simply impossible with the kind of stress that we have in our lives, and we have to take care of our second person. It is difficult. All said and done, it is difficult. We don't want that functional outcome, right? So when you say functional outcomes, you talk about these scores, modified Rankin score, Barthel index, and all these things. So you'll hear these terminologies. Modified Rankin score of 4 or 5. So what they found out is, in these 51 number of patients when there were small vessel strokes, favorable outcome was seen in 75%. Matlab, out of 4, 3 people get favorable outcome when they actually use we'll see the outcomes of these patients. So the large vessel strokes are the one which has the biggest problem, if you look at it. Large vessel strokes. See the large vessel strokes? 49, 40, 45, 33. So they are not looking good. It is a large vessel strokes that have a problem. Small vessel stroke seems to be doing well, yeah. Small vessel stroke, the outcomes of these patients, they seem to be somewhat doing well. So if you have a small vessel stroke, I'm okay. What I have to find out? Large vessel stroke. Because that is the problem. My problem is large vessel. Hello? This category of patients are the one that have not a very good outcome, is what it looks like. Isn't it? Now if you look at it with TPA, look at the outcomes, they are better. Look at it. This is with TPA. With TPA, relatively better outcomes than without TPA. So what is clear? Give TPA. That is clear. Let it be small vessel, let it be large vessel. The large vessel seems to respond better to TPA as compared to the small vessel strokes. As compared to the small vessel strokes, the large vessel strokes seems to respond better. When I say large vessel, means you're looking at carotid, MCA, left MCA. So these small teeny strokes में TPA का उतना फायदा नहीं होता है जितना हम लोग look at large vessel strokes. So with cardiomyopathic stroke, there doesn't seem to be much of a difference if you look at it. Cardiomyopathic stroke. So which are the strokes I am concerned and you are concerned with? Large vessel. Finding out the large vessel strokes. So in short, if I clinically can pick up a large vessel stroke, CT scan can pick up a large vessel stroke, that is the patient that will have probably the best outcome as compared to the cardioembolic kind of strokes. Okay, but across the board, TPA does some benefit. Now, what is the benefit that TPA does? This is what it is. So, what is this? This is a group of patients that receive TPA. In that particular NIHSS study, this is a group of patients that record TPA. Okay, so this is within 3 hours. Within 3 hours, they got TPA. Among these 100 patients, 32 of them, 32 of them did well. 32 of them had very good outcome. Only 3 had unfavorable outcome after TPA. So out of 100 patients, at least 32 you can do something. That is what I am trying to tell you. It is not 100%. So when you tell your patient that I am going to give you TPA and he'll be fine, you're wrong. At 90 days, out of 100 patients, 32 will do well. Out of 100, 32 will do well is what we know from the NIHSS score. 3 will have unfavorable outcomes also. So this is what I'm going to explain to your patient whenever you are actually looking at TPA. So you say 6% approximately will have unfavorable outcomes as compared to the entire population is what we normally see. Okay, 6% has a chance of bleeding, IC average. There is another IC average. So 32 patients do well. So if somebody asks you, क्या है गारंटी है कि इससे ठीक हो? गारंटी कुछ नहीं है. लेकिन 32 आप 100 में से 32 जन का इंप्रूवमेंट होता है, फेवरेबल आउटकम आता है. वैसे फेवरेबल आउटकम at 90 days with respect to all these scores that we talked about, modified Rankin score, Barthel index, Glasgow outcome scale. Clear? So at 3 hours, this is what happens at actually 3 hours. So now some years ago, if within 4.5 hours I received TPA, I had an outcome which said 32 patients do better as compared to the rest of these patients. Now what has happened is, it was still, otherwise it was still an aspirin. Otherwise after 4.5 hours, it was still biophilic aspirin de do. Hardly anything to do, aspirin de do. This was what it was. But now we know things have changed more. We now know things have changed more. Clear? So you can imagine how history has moved from doing nothing to giving something which has improved mortality, and now giving something more. You understand? History has moved. So we still have some more. Much more we have, in fact, not just more, we have much more. The important thing again goes back to the same thing. Recognize the stroke. Pick up the stroke. Find the stroke. Isolate the place where it is. Isolate whether it is a large vessel. This is very, very important. So at the end of the story, it still boils down to the clinical know-how as to whether you are able to pick up the stroke or not in the first place. That is very, very important. So these are examples of large strokes, right? Middle cerebral artery. This is what it looks like, the whole artery getting spoiled. This is what it looks like. Okay, then you have the basal territory artery. It's easy to pick up these strokes, but it's very difficult to pick up these kind of strokes that come in. Okay, very, very difficult to pick up these posterior hereditary strokes, where you have hardly any ataxia or hardly any vertigo that is coming in. So these are those strokes, but these are still large vessel occlusions. These are still not small strokes, they are large vessel occlusions. So maybe we'll have something to do with this. What if the patient is present after 4.5 hours now? Say for example, you are here, patient is presented, the usual thing is after 4.5 hours they presenting. You have to rule out large vessel occlusion. So I am not really busy with small vessels anymore. हम लोग अभी तक small vessel, large vessel, 4.5 hours, give TP. This is what we thought. Small vessel, large vessel, whatever stroke type it may be, give the TP. This was what it was. Once it's beyond 4.5 hours, rule out large vessel occlusion, because that is where we can intervene even after 4.5 hours. Clear? Clear? That is where we can intervene even after 4.5 hours. How do we do this now? Look at this. Okay, this is the syndrome that you're looking at. After you have to pick up, the entire thing was pick up, right? The entire thing you have to pick up. Large vessel, large vessel, you're talking about large vessel. How do you pick it up? This is an MCS syndrome. If a patient presents with contralateral face, arm, limb weakness, gaze deviation, aphasia or neglect, this is an MCA plus syndrome. This is a middle cerebral artery syndrome. Okay, this is one of those patients that may benefit even after 4.5 hours with an intervention. Clear? Clear on this? Similarly, you have basilar syndrome, very important, disordered consciousness, gaze palsy, crossed weaknesses, sensory disturbances, vertigo, ataxia, imbalance. Another case that you can salvage, because they are large vessel occlusions, because they are probable large vessel occlusions. Go back to what we are going to do, CT and Joe, we're not going to that. We are just saying clinically what you have to pick up. So if you have a patient who calls up and says, थोड़ा सा चक्कर आ रहा है, बीच में बेहोश हुआ था लेकिन चक्कर अभी खाली चक्कर आ रहा है, मैं बेहोश हुआ था, डिसऑर्डर कॉन्शियसनेस था, बट अभी खाली थोड़ा सा चक्कर आ रहा है. What should we are thinking first? शुगर नहीं, स्ट्रोक है क्या, ये स्ट्रोक है क्या, TIA है क्या, बेसिलर स्ट्रोक है क्या, and it's beyond 4.5 hours. You come, you examine, look at his face, whether there's weakness, no weakness, examine him completely. Rule out of basilar plus syndrome. Okay, rule out by doing imaging over here. Very, very important. Okay. So, if you look at this, now look at this patient. Okay, left gaze preference, subtle drift in the right upper extremity, mild facial weakness on the right, mild to moderate aphasia. Okay, ऐसा patient अगर आएगा, फिर थोड़ा सा tingling हो रहा है यहाँ पर, हाँ हाथ थोड़ा सा weak लग रहा है मेरे को. Patient fully conscious है. You are used to seeing critical patients in the ICU who are on the ventilator and not able to, but this is critical. This is actually critical. He is having some small mild weakness here, some mild arm drift, but this is the patient who is having MCA. This is the patient who is having MCA syndrome. Are you understanding? Patient is fully conscious and obeying your commands doesn't mean that it doesn't require an intervention. This is the patient who will probably benefit with an intervention, because if you leave him this way, he's going to go to a complete stroke. This is the kind of calls that you might get. This seems like a mild stroke, but still requires extremely quick intervention. As I told you, 1.9 million neurons per minute is getting lost in that patient. Okay, you leave him that way, he's going to go down. This sounds very simple. If you look at this, sounds very simple. You would often say, so हाथ झटकने पे मैं ठीक हो रहा हूँ या sugar water दे दो वो ठीक हो रहा है. This is the thinking that will happen when something like this occurs. When something like this occurs, the thinking would be, अरे यार ये तो कुछ भी नहीं है, तो hypoglycemia है. But it is not hypoglycemia. You must be able to first rule out the most difficult pathologies, of which large vessel occlusion is very important because this requires extremely quick intervention. Extremely quick. So quickly a CT angio needs to be done. Quickly, you have to do this. There is no doubt about it. A CT angio followed by mechanical revascularization is what's required after 4.5 hours. Now you must know this, that if you don't pick it up only, the organization of the CT angio with mechanical revascularization is impossible. You have to organize this thing. It's not easy to organize this thing. The radiologist has to come, intervention neurologist has to come. There has to be the devices over there. People have to do all these things. It's not easy. It's not easy. That is why CT angio with mechanical revascularization, if you have to do it fast, you have to first pick it up fast. That's the most important thing. Okay. Now the question that comes is, अरे I have already given TPA. Patient आया था, 4 घंटे पे आया था, यही फीचर था, मैंने डायग्नोस किया और मैंने उसको TPA दे दिया. अभी क्या करूँ? What is the thinking? Chandrima, I've given TPA. Now what? Abhi we just talked about mechanical revascularization. Question is, he has a large vessel occlusion. I have given TPA. Do I need to do it or not? What would happen? So the answer is, the stroke is mild. If the stroke is mild, even then it is important that we do a mechanical thrombectomy here. Large vessel occlusion होता है. Don't just rest by saying अभी वो ठीक होएगा. अगर वो large vessel occlusion है, तो try to get a mechanical device in place, because there are data that says if you do thrombectomy plus TPA versus TPA alone, 34 patients do well and there are no problems at all. So larger number of patients seem to be doing better. Favorable outcome was seen with larger number of patients, and only one patient of the whole list that they did look at had a problem. So if I have a mild stroke, I have given TPA, I will not sit on it. Because I have diagnosed CT angio, that is why CT angio becomes important. You understand the importance of CT angio now? A plain CT will not show you a stroke. You have thrombolized because the plain CT did not show hemorrhage. But now what are we going to think? Is it large vessel occlusion? Because I have picked it up this way that he had aphasia, right side AO. I will do a CT angio, because if it is CT angio positive, what do I require to do? Mechanical revascularization. So on that I can't just do a CT and just thrombolize and wait. Clear? Because large vessel occlusion है. Large vessel occlusion will not respond to that TPA as well. Clear?
Sir, after rule of hemorrhage.
Yes. So normally what will happen? Normally you have a mild patient that comes to you. Okay, your mild में NIH is 7. थोड़ा सा aphasia हो रहा है, थोड़ा सा lip weakness है, तो आपने calculate किया NIH is 7 आ गया. Is in the window in which you want to probably thrombolize this patient. Okay, he's come within say 4 hours. He's come at 4 hours exact. Now you do a CT. You have ruled out hemorrhage. Because you did a CT. There is no hemorrhage. I decided to do TPA. I started TPA. But then what you do? You wait. चलो अभी TPA तो दे दिया, हमारा काम हो गया. You don't have to wait here, because this is showing MCA signs. I do a CT angio. See whether there is large vessel occlusion. Let the TPA be on. Arrange for mechanical revascularization. समझ में आ रहा है? Are you understanding? The mistake that we do here is, we have a small stroke, we give them TPA, and we think we have done our job. No, our job is not done. This is probably large vessel occlusion. I need to look into that further. You are understanding? Are you understanding what I am saying?
After TPA, you have to do CTA.
Not required. Not required.
So in the start only you will do CT angio.
Ideally, that's why the pickup is important. So if you pick it up saying that this is looking like MCA, what I will do? CT angio. At the same sitting, you got the point. I will do the same sitting at that. That's a pickup becomes the most important here. For Bachelor and for MCA, the pickup becomes very, very important. Are you understanding? We have gone beyond that simple actylase injection. We are into mechanical revascularization. And for that, I cannot do it in small vessel, it has to be large vessel. So CT angio. That's why even for an IC hemorrhage, the CT angio becomes important when you do it. Okay, CT angio. So thrombectomy versus no reperfusion therapy, ऐसा भी अगर किया thrombectomy is still better. So even at 4.5 hours, if you have not given TPA, still go for mechanical revascularization because 44 patients do well as compared to not having not having any procedure now. Clear on this? So now we have a window that initially we had only aspirin when we were doing our things. We came to a 3-hour window with Actilase. 10 years later, we came to a 4.5 windows for Actilase. And now we are in the era where we are beyond 4.5 hours for large vessel occlusions. This is not the same for small vessel occlusions. It is for large vessel occlusions. Clear? So now we have a window period that is kind of gone a little bit better as compared to small vessel occlusions. Clear on this? Clear? Clear? So you may have this phone call coming from your friend, you know, that he was okay. He was okay. थोड़ा सा ऐसा weakness हो रहा है, खाली right side में तो weakness हो रहा है. So you know, normally हम एक CT कर लेंगे. CT में कुछ आया नहीं, सब यार कुछ भी नहीं है. चलो फिर भी thrombolysis तो कर ही लो. That's the end point of the story. It cannot be that. Cannot be the end point. The end point should be CT angio, less large vessel occlusion. If it is there, go for mechanical revascularization. Because otherwise neurons will be lost. 3 months more. We are looking at 3 months. We are looking at 3 months. 3 months later, what if you are not able to do your usual register activities? For example, you are an accountant in a hospital, accountant in a company, and you have to do algebra, to get their accounts done. That is your job. You are living because you are getting money being paid from your as an accountant. And then 3 months later, because those neurons are gone, which were actually responsible for doing that work, he cannot do that work. He is stuck. We are not looking at that moment. We are looking at the moment at 3 months. That is what you must remember. Okay. Now what about this thing? He woke up like this. He was sleeping in the night. He woke up with the right side weakness. Now, up till now, we were talking about you have a 3-hour window, you have a 4.5-hour window, you not for an hour. Now what to do now? He's woken up. रात को सो गया 10 बजे, सुबह उठा तो right side काम नहीं कर रहा. It's called wake up stroke, right? It's called wake up stroke. So don't think we can do much? No. There is MRI guided thrombolysis here. Okay. Now at this stage, when the patient comes to you, quickly get an MRI. Quickly get an MRI. Okay, this is data that has come out 3-4 years ago, where what they did was, whenever these patients came, they looked at the MRI and looked at the deficit. They looked at perfusion imaging, something called perfusion imaging. Okay, they found the deficit being small, perfusion being big. Okay, that means there's a clinical diffusion mismatch. There's a mismatch between what is clinically seen and what is seen over there. We're assuming that there is a huge amount of penumbra, or an area that will probably help with revascularization. So that also can be offered to these patients. So even if it's a wake-up stroke, MRI guided thrombolysis is something that has come in picture. And what they found out with this was freedom from neurological deficit even after 4.5 hours, or major disability that was 11.5 percentage points higher than that in the placebo group at 90 days. That means at least 10 patients out of 100 are doing better even after in a wake-up stroke. At least 10 patients. We know that the whole prognosis is bad in these patients, but to get a kind of an improvement, you should understand these important points that I'm talking. Okay, so 11.5% percentage points will be higher. This is Aldi+, this is placebo. This is a modified Rankin scale. This is the outcome scale at 90 days. So what happens is when you give Aldi+, the percentage of patients that are going into the scale 6 are still higher as compared to the one placebo. Okay. Actually, a golden hour is actually there is a video now. We can use maybe. Okay. Okay. Any doubts on this? This is very small. You start yours now.